Welcome, whoa! Welcome, everyone. Welcome to Generation Next. This is my Instagram Live. I am the good Dr. Hade. Thank you all for coming and joining us today. It's a very exciting lecture. Or is this a lecture? I don't even know what it is. Discussion, a topic. Please, I would love for anyone, if you have questions, concerns, please, this is the time to talk and bring it up. But today we're going to talk about something very dear to me. I don't know if it's dear to anyone else, but I love the uterus. And I think that it's, when you look at infertility, it only really accounts for maybe 1% of all infertility, true infertility issues, but it's involved. It's a critical component of creating a baby. You need eggs, we know. Obviously, you need sperm, thank God, for people like me. That means men. And you need a uterus, right? You need a place to incubate the embryos. So let's talk about what the natural progression is and how things go. And so, like, why we're so meticulous when we're doing embryo transfers and how we're monitoring things, especially if fresh or versus frozen cycle. So let's get right into it. So I think let's show here, we're going to try and do something new. Try and show some images today. But let's start here with what is a normal uterus. That is a normal looking uterus and cavity. So you can see that one right there. So basically when we're looking at the uterus and the uterine cavity, there are changes that are happening inside the uterine lining called the endometrium. And the endometrium is what is developing. It's the home for the embryo, right? And it's where the baby is going to implant. The embryo is going to implant, make a baby. And the point is that these changes are occurring while the follicles are developing to release the egg. So it's in conjunction. There are very specific changes that occur prior to ovulation, on ovulation, and post-ovulation. So the critical part is that the uterus contains glands which secrete sugars and other types of proteins and hormones. It has all the stuff that's required for the embryo to survive. And there's also a blood supply and blood vessels there that allow gas exchange. So when the embryo implants and you have the villi and the trophectoderm, which are the ringlet cells on a blastocyst, I'm really not prepared with images here, but when you have a blastocyst, that's what's implanting, and then it creates the placenta, and that's what's invading into the maternal blood supply. So that's why when you're looking at all these different structures that are happening and we're measuring the growth, we want to make sure that the environment is hospitable for the embryo. And there are very specific changes that occur once ovulation occurs, because you go from an estrogen-producing environment to a progesterone environment. And in a progesterone environment, most women, and if you look in, this is why we do certain tests, such as an endometrial receptivity assay, 80 to 85% of women will have that normal window of receptivity, where their peak window will be roughly at about 122 hours from progesterone exposure. And that only occurs once ovulation. So upon ovulation, that's when it's like the fuse is lit and you go from making estrogen to progesterone. So there are lots of things that we look at. Is the anatomy of the uterus normal? Because if it's not, that may increase the risk of not necessarily implantation failure, but miscarriages and other issues down the line, which are equally as relevant, right? Because you work really hard, and we work really hard with you to not only create the eggs, make embryos, but once you transfer it, even if there's a pregnancy, that's amazing, that's great. But what happens then if it leads to miscarriage? And that's why we're very dogmatic in how we evaluate the uterus. So let's talk about some of the questions that some of our patients have inquired about. So, and we have the lovely and talented Rachel here. Rachel, come say hi. I know that
Hi.
Okay, fantastic. And so tell us, Rachel, what's the first question?
How do you know if you have a uterine anomaly?
So how do you know if you have a uterine anomaly? So part of the initial workup that most patients will receive is a test called a hysterosalpingogram, or an HSG. And essentially that's a test where you go to a radiologist, or some fertility centers do it, that have these machines that can do the fluoroscopy. And what you do is you put a small catheter into the uterine cavity, inject the radiopaque contrast, and you're doing live x-rays called fluoroscopy, and you're looking as you're injecting to see if this contrast is how it's filling the uterine cavity. Is it filling it in a normal pattern, or there's some type of defects within the cavity, anatomic defects such as fibroids, most commonly polyps, scar tissue or adhesions, also known as Asherman syndrome, and also are there other problems? Like, is the contrast continuing to flow through the tubulostia, which are the openings in the uterus, the little spaces that are I think of them more like how your eyelids, where they open and shut, and they allow the dye to go through, and allow you then can evaluate the fallopian tubes and see if they're open. And as well, as once it spills into the uterine, into the pelvic cavity, you can then assess, are there scar tissue, like then you can surmise maybe endometriosis, or if you've had past surgeries like fibroid surgery or bowel surgery, you can see, are there scar tissue still present around the fallopian tubes. So that's really the primary test to tell you what's going on with the shape of the cavity. You could do things like saline sonohistograms, unless you're doing a 3D saline sonohistogram, which is basically an ultrasound where we're taking the same catheter that you use for the hysterosalpingogram, but you're injecting saline water into the cavity. And when you do that, you can then evaluate. It's really great to see the cavity that way. And you can see whether or not there's any filling defects, or really the shape of the uterus as well. A third way you can always assess this is an MRI. That's way more expensive. And obviously hysteroscopy, which is the gold standard, putting a video camera into the uterus and evaluating the cavity that way. So when you're looking at both the musculature and... Don't be mad at me. I think that this shut off. If you can turn that back on. Oh, wonderful. So let's go through. So we said this was the normal cavity right there. And then let's go through what's the differences. So here's a woman who would have some type of problem called a bicornuate. And you can see here it's more of a heart-shaped uterus where it's almost split down the middle. The most common is what's called arcuate, which is... really a variation of normal, and there's nothing to do for these type of cavities, but you can see starting to have these little septum starting to form, and you don't usually resect or do anything for an arcuate uterus, and it doesn't cause complications. But the most common anomaly to cause miscarriages is something called a uterine septum. That's where you have this avascular band, so it's just how the uterus is formed. It's congenital malformation at birth. And it's no big deal. And these are actually pretty easy to fix for most individuals. And lastly, you can have what's called a unicornuate uterus, where you only have half of the uterus that's been formed. That usually does not involve or increase the risk of miscarriage, but it does increase the risk of preterm labor and delivery. So, you want to be very careful with how many embryos you transfer in a woman with a unicornuate uterus. You want to be careful when you're doing especially IUIs in these individuals, because they may have the other half of the horn may have formed but never connected to the actual cavity, and as a result you have this non-communicating horn, which can then get a pregnancy and act more like an ectopic or tubal pregnancy, believe it or not. So really a lot of fascinating, strange things and how the human body develops, and that's why we look at these things and say, okay, we're trying to get you to the end game, which is having a baby, right? That's always your goal and our goal. And we have to say, how do we do this with having the fewest amount of losses and the best success each time? And that's why these evaluations are pretty important to do in the beginning, rather waiting until, oh, I had a miscarriage, and then you come in and you say, or I've had 2 miscarriages, then you do a test, you say, oops, look what you have, let's go fix it now. And then you fix it, and then you solve the problem for some of these individuals. I want to introduce Steffi. Say hi, Steph.
Hi. Hi.
She's brand new to the Hade concierge team, right? Here on Third Party. She is an extraordinary woman, right? Future MD. And so wave hi, and then let's say, okay, what's the next question, Steph?
All right, next question is people want to know if they're doing fertility treatment, when in the process should they start thinking about evaluating any uterine abnormalities?
So when should you evaluate for uterine anomalies? So I would tell you from the get-go. So it's part of the initial evaluation. So usually if you're saying, okay, let's do the testing, I've never had testing, and you want to see what options you have open, I usually will try and do it in part of the initial testing. However, if someone's doing IVF, I try not to put them through an HSG because it can be uncomfortable, because the iodine that's in the contrast for an hysterosalpingogram is acidic and it burns when it passes through into the pelvic cavity. So under those circumstances, I'll do an SIS or a hysteroscopy to evaluate the uterus, because we're bypassing the tubes. We don't care if they're open, and that's really the strength of an HSG. I hope that answered it.
Sounds good.
Okay, what else?
What is a tilted uterus, and how does this impact
Oh,
fertility and pregnancy?
The fabled tilted uterus. Wow, the tilted uterus. So, and I know Dr. Luke, if any of you watch, and I'm hoping all of you watch her Instagram live, she talks about the tilted uterus all the time. And she yells all the time, everyone's uterus is tilted, which is somewhat true. It doesn't matter. Most women's uterus is pointed up, or we call anteverted, meaning it's tilted coming up towards the bladder. Some people it's pointing down, going towards the rectum, and some people it just goes straight up towards your abdomen and your neck. So it doesn't matter. All that matters is when the uterus is tilted, when you're doing some type of catheterization, because catheters are straight, and if most uteruses are tilted, there's a bend, and it just makes it a little bit more challenging to get a straight catheter into a curved structure. But it means nothing. So that's the bottom line. It means nothing. I hope that answered it.
I did.
I hope I put it to rest. Please, no more with the tilted uterus, everyone. No more.
Are uterine abnormalities genetic?
Are uterine abnormalities genetic? That's a great question. I don't know who asked that, but that is really a fantastic question. The problem is that we don't know. And I would tell you probably yes for some abnormalities, and other abnormalities are probably caused by environmental factors and differences in the environment and what you're exposed to in life. And I'll give you an example of this. Like, for example, if you have chronic endometritis, which is an infection inside the uterus, which can reduce implantation of an embryo, then that's an environmental thing from usually some type of bacteria that is transmitted, either sexually transmitted disease or just abnormal bacteria that's in the vaginal canal that's ascending up into the uterine cavity. Fibroids, when you look at fibroids, this is a really interesting fact. The majority of fibroids are chromosomally abnormal. When did these cells become abnormal? Nobody knows. If you were born that way, or while the uterus was developing, did the cells just divide abnormally when they were making the uterus, which is a smooth muscle, not a skeletal muscle. So like your arms, your legs, all the muscles that you move with, that you control, is called a skeletal muscle. Things that you have no control of, smooth muscles, like your bowel, the uterus, these are things that you can't control, that have their own action and movement. It's one of the smooth muscles, and the most common tumor found in 50 to 70% of all women are what we call myomas or fibroids, so which are very common tumors but may be genetically inheritable. So we know different ethnicities have higher rates than other ethnicities. I hope that answered.
Mm-hmm. We do have a comment.
Oh, we have a comment. Oh, amazing. Someone's actually watching. So someone here is, and I don't know if I'm going to pronounce this right, so insatiable blog. Am I doing right with that? I hope so. I'm sorry if I'm not. Interesting. I have a divided uterus, waiting for surgery to remove the septum, hoping it may help with my reoccurring loss. I had the sonohysterogram, which is when I found out about my uterus. Oh, so amazing. You see? Yeah, so it's really common. So when you look at things like, when you're looking to decide, okay, when you have this uterus that has this septum going down the middle, you want to know, is it a bicornuate, meaning that it's a heart-shaped uterus? Because if you try and cut that, you're going to make a hole in the uterus because the septum's coming down, but it's really not a septum. It's just the uterus never fused when it was forming. So the way that it works is you have two horns of the uterus. The first thing they do is they migrate down, and then they fuse while they're migrating, and then it gets reabsorbed to create a cavity in all the spaces. So it creates the uterus, the same structures that create the uterus, create the fallopian tubes, uterus, and the upper 2/3 of the vaginal canal. So all of these things, it could be deviations and errors in all parts. And so there are some people who have septums in the vagina that can be vertical or they can be horizontal septums. They can also be in the uterus. It could be, you could have people with two cervixes coming in, two separate complete uteruses that formed, never fused, but everything else functioned normally. So you have two independent uteruses, which we've seen many a times and have pregnancies with. So they act more like unicornuate uteruses. So those individuals just higher rates of, like, when they do get pregnant, preterm labor and delivery and requiring C-section, because the baby can't flip and is usually in a breech presentation. So yeah, I think that's fantastic that they found this issue for you, and if it's corrected appropriately, you should have a much higher probability of going to a full-length pregnancy and a live birth. We're hoping the best for you. That's amazing. Any other questions?
Are uterine anomalies the same as Müllerian anomalies?
So Müllerian just refers to the structures, which are embryologic structures, and the uterus is part of the Müllerian structures. So the answer is, as I mentioned before, that's what we were talking about Müllerian, is that it starts off with the fallopian tubes, the uterus, and the upper 2/3 of the vagina, and that's part of the Müllerian structures that all part of the same thing. In a simple way, just to make it simple for everyone.
The last question is just about how the role of uterine evaluation in implantation failure. So I guess they're asking, for what different types, or what would you be worried about with implantation failure in terms
Right.
of
So here's the hard thing. It's rare to have repeated. It's the minority of patients that have repeated implantation failure, and what you're looking at is saying you have to assess this two different components here. You have the embryo, and then you have the uterus. So it's hard to decipher because you can't do true experiments where you're taking an embryo, cut it in half and cloning it, and then putting one in you and one in someone who does not have miscarriages or does not have implantation failure, because then you could see, is it an embryonic issue or is it a uterine issue? But we do know that's why we do certain tests. For example, there are certain disease states of the uterus, like adenomyosis, which is endometriosis, where the lining of the endometrium, those glands are not limited to the endometrium, but start to invade into the uterus itself and start to go into the musculature of the uterus, and that's called adenomyosis. Other diseases, as we mentioned before, fibroids, polyps, chronic infections of the uterus can all reduce the implantability of an embryo. And then there are just unknown causes of why women are not having implantation success. So that's why there are other tests such as the Receptiva test, the ERA test, the EMMA test, which looks at, are there specific, let's say in the EMMA test, you're looking at very specific bacteria that can cause chronic infections that if you treat may improve the implantability of the uterine cavity. If there are polyps, you need to resect those polyps. And they're sometimes not easy to get completely resolve, because there are some women you resect the polyps and within a few weeks later they grow right back. That just shows you there's probably some underlying infection because the polyps are just growing on a bed of inflammatory tissue. So that needs to treat the underlying cause. And usually when you resect that and resolve it, then those women usually get pregnant right away. If you have fibroids, obviously that's a space-occupying lesion that can cause bleeding and other factors. It's not a normal environment where an embryo can implant, so that needs to be resected. If you have a septum, remember a septum is a dead space, so there's no vascular tissue. It may not reduce the implantability of the embryo, that's the unknown, but it's depending on how long that septum is. If it's occupying 30% is different than 50%, that's different than 90% of the cavity being occupied, then that needs to be resected, removed to increase the outcome. So when you're looking at the ERA test, you're looking to say, okay, are you making the endometrium responding to progesterone appropriately so that on the day of implantation, the cavity and the endometrium has sufficiently made changes that are allowing optimal secretion of the glands, and that it's all the nutrients are there and the growth factors are allowing the embryo to stick? Or are you responding inappropriately to the progesterone and your peak window of implantation is either 24 hours earlier or 48 hours earlier or 24 hours later or 48 hours later compared to the standard time of that, as I mentioned before, the 122 hours from progesterone? And in some of those women that you change that window who have this altered expression, and it looks at their RNA content, specific RNAs that are expressed during specific times of the implantation window, and you alter it so you can match the embryo to where it's supposed to be, those women may have a higher probability of pregnancy and live birth. So when people say, hey, Dr. Hade, I read an article and a study that said the ERA is ineffective. Well, yeah, because they're looking at only the majority of women that they changed were in that receptive window, and it was only that 12-hour change. So I disagree. I think that when you look at the extremes and you look at the extremes that you change, those are the women that actually do the best. The women who have a normal receptive window and you're transferring embryos and they're still not getting pregnant and they have a receptive window that's a normal time, then you say, okay, it's obviously not a uterine issue, it's something else and maybe isolated to the embryo, and that's where it becomes challenging. And lastly, we talked about the Receptiva test, which looks at risk factors for endometriosis, and they look at a marker called PCL6. And what's interesting about that is that if you have this marker expressed, which is both in endometriosis and if you have a disease of the fallopian tubes called hydrosalpinx that causes infectious fluid to build up into the tube, those women, they show that there's an improvement in outcome and implantation if you give them 3 months of Depo-Lupron. So these tests are really designed for recurrent implantation failures, and we start to look at doing it for all patients. It starts to cloud the information. It starts to cloud whether or not how useful it is, because we're trying to generalize something that had a very specific target or audience to begin with. So you may not be able to generalize things and say it's good for everyone, but for the select group of individuals, it may be ideal for. So I hope that was helpful. I hope everyone loves the uterus as much as I do and understands that it's super important. And thank you very much. And I have to give our next IG Live will be Wednesday, December 14th with Dr. Luke. Oh my goodness. And the next Candid Conversations is Thursday, January 5th at 6 p.m. Wonderful. Well, keep it coming, guys. Whatever questions you have, whatever topics you think we should talk about, let's make it happen for you. So please write in and tell Javi what you think we should talk about. Love to hear from everyone. Have a wonderful evening, and may all your fertility wishes come true. This is Dr. Hade signing off.